Iggy 830 to 838, hypovolemic shock. Hypovolemic shock, pathophysiology. The basic problem of hypovolemic shock is a loss of blood volume from the vascular space, resulting in a decreased mean arterial pressure, or MAP, see figure 39.2, and a loss of oxygen carrying capacity from the loss of circulating red blood cells, RBCs. The reduced MAP slows blood flow, resulting in decreased tissue perfusion. The loss of RBCs decreases the ability of the blood to oxygenate the tissue, it does reach. These oxygenation and tissue perfusion problems lead to cellular anaerobic, or without oxygen conditions, and abnormal cellular metabolism. The main trigger leading to hypovolemic shock is a sustained decrease in MAP that results from decreased circulating blood volume. A decrease in MAP of 5 to 10 mmHg below the patient's normal baseline value is detected by pressure-sensitive nerve receptors, or baroreceptors, in the aortic arch and carotid sinus. This information is transmitted to brain centers, which stimulate adjustments, adaptive or compensatory mechanisms. These mechanisms ensure continued blood flow and oxygen delivery to vital organs while limiting blood flow to less vital areas, moving oxygenated blood into selected areas while bypassing others, or shunting causes the manifestations of shock. Table 39.3, adaptive responses and events during hypovolemic shock. Initial stage, decrease in baseline mean arterial pressure, or MAP, of 5 to 10 mmHg. Increased sympathetic stimulation, mild vasoconstriction, increase in heart rate. Non-progressive stage, decrease in MAP of 10 to 15 mmHg from the patient's baseline value, continued sympathetic stimulation. Moderate vasoconstriction, increased heart rate, decreased pulse pressure. Chemical compensation, renin, aldosterone, and antidiuretic hormone secretion, increased vasoconstriction, decreased urine output, stimulation of the thirst reflex. Some anaerobic metabolism in non-vital organs would be mild acidosis and mild hyperkalemia. Progressive stage, decrease in MAP of greater than 20 mmHg from the patient's baseline value, anoxia of non-vital organs, hypoxia of vital organs. Overall metabolism is anaerobic, moderate acidosis, moderate hyperkalemia, and tissue ischemia. The refractory stage, severe tissue hypoxia with ischemia and necrosis, release of myocardial depressant factor from the pancreas, buildup of toxic metabolites, multiple organ dysfunction syndrome, or MODS, and death. If the events that caused the initial decrease in MAP are halted at this point, the adaptive or compensatory mechanisms can return the body tissues to a normal perfusion and oxygenated state, even without outside intervention. If the initiating events continue and MAP decreases further, some tissues function under anaerobic conditions. Or some tissues, if the initiating events continue and MAP decreases further, some tissues function under anaerobic conditions. Okay, this condition increases lactic acid levels and other harmful metabolites, e.g. protein-destroying enzymes and oxygen-free radicals. These substances cause electrolyte and acid-base imbalances with tissue-damaging effects and depressed heart muscle activity. These effects are temporary and reversible if the cause of shock is corrected within 1 to 2 hours after onset. When shock conditions continue for longer periods without help, the resulting acid-base imbalance, electrolyte imbalances, and increased metabolites cause so much cell damage in vital organs that multiple organ dysfunction syndrome, or MODS, occurs, and full recovery from shock is no longer possible. Table 39.3 summarizes the adaptive responses and events during the progression of shock. Stages of shock. The syndrome of shock progresses in 4 stages when the conditions that cause shock remain uncorrected and poor cellular oxygenation continues. These stages are 1. Initial stage, 2. Non-progressive stage, 3. Progressive stage, and 4. Refractory stage. The stages are defined on the basis of how well compensatory mechanisms are working, the severity of the clinical manifestations, and whether tissue damage is reversible. Initial stage of shock, early stage. The initial or early stage of shock is present when the patient's baseline MAP is decreased by less than 10 mmHg. During this stage, adaptive compensatory mechanisms are so effective at returning MAP to normal levels that oxygenated blood flow to all vital organs is maintained. The cellular change in this stage is increased anaerobic metabolism with production of lactic acid, although overall cellular metabolism is still aerobic. The adaptive responses of vascular constriction and increased heart rate are effective, and both cardiac output and MAP are maintained within the normal range. Because vital organ function is not disrupted, the manifestations of shock are difficult to detect. A heart and respiratory rate increase from the patient's baseline level or a slight increase in diastolic blood pressure may be the only objective manifestation of this early stage of shock. Non-progressive stage of shock, compensatory stage. The non-progressive or compensatory stage of shock occurs when MAP decreases by 10 to 15 mmHg from baseline. Kidney and hormonal adaptive or compensatory mechanisms are activated because cardiovascular adjustments alone are not enough to maintain MAP, and supply needed oxygen to the vital organs. The kidneys and baroreceptors sense an ongoing decrease in MAP and trigger the release of renin, antidiuretic hormone or ADH, aldosterone, epinephrine, and norepinephrine. Kidney compensation occurs through the actions of renin, aldosterone, and ADH. Renin secreted by the kidney starts the reactions to decrease urine output, increase sodium reabsorption, and cause widespread blood vessel constriction. See Figure 13.6 in Chapter 13. ADH is secreted by the posterior pituitary gland. ADH increases water absorption in the kidney, further reducing urine output, and also causes blood vessel constriction in the skin and other less vital tissue areas. Together, these actions adapt or compensate for shock by maintaining the fluid volume within the central blood vessels. Tissue hypoxia occurs in non-vital organs, e.g. skin and the GI tract, and in the kidney, but it is not great enough to cause permanent damage. Because some metabolism is anaerobic, acid-base and electrolyte changes occur in response to the buildup of metabolites. Changes include acidosis, or low blood pH, and hyperkalemia, increased blood potassium level. Manifestations of the non-progressive stage of shock include both subjective and objective changes resulting from decreased tissue perfusion. Subjective changes include thirst, sensation, and anxiety. Objective changes may include restlessness, tachycardia, increased respiratory rate, decreased urine output, falling systolic blood pressure, rising diastolic blood pressure, or falling systolic, rising diastolic, narrowing pulse pressure, cool extremities, and a 2% to 5% decrease in oxygen saturation measured by pulse oximetry. Comparing these changes with the values and manifestations obtained earlier is critical to identifying this stage of shock. If the patient is stable and adaptive mechanisms are supported by medical and nursing interventions, he or she can remain in this stage for hours without having permanent damage. Stopping the conditions that started the shock at this stage and providing supportive interventions can prevent the shock from progressing. The cellular effects of this stage are reversible when nurses recognize the problem and coordinate with the healthcare team to start appropriate interventions. Progressive stage of shock or intermediate stage. The progressive stage of shock occurs when there is a sustained decrease in MAP of more than 20 mmHg from baseline. In this stage, adaptive or compensatory mechanisms are functioning but can no longer deliver sufficient oxygen even to vital organs. In fact, these helpful mechanisms use large amounts of oxygen in some tissues, e.g. the heart, which worsens the problem of poor oxygenation. Vital organs develop hypoxia and less vital organs become anoxic or no oxygen, and ischemic, cell dysfunction or death from lack of oxygen. As a result of poor oxygen and a buildup of toxic metabolites, some tissues have severe cell damage and die. Manifestations of the progressive stage of shock include a worsening of both subjective and objective changes resulting from decreased tissue perfusion. Therefore, continuous monitoring and comparison with earlier findings is critical at this stage to assess therapy effectiveness. Subjective changes include severe thirst sensation and deeper anxiety. The patient may express a sense of something bad about to happen. He or she may have some immediate confusion. Objective changes are a rapid, weak pulse, low blood pressure, pallor to cyanosis of oral mucosal membranes and nail beds, cool and moist skin, and anuria, and a 5% to 20% decrease in oxygen saturation, measured by pulse oximetry. Laboratory data at this stage may show a low pH, rising lactic acid level, and rising potassium level. The progressive stage of shock is a life-threatening emergency. Vital organs can tolerate this situation for only a short time before becoming damaged permanently. Immediate interventions are needed to reverse the effects of this stage of shock. Tolerance varies from person to person and depends on age and pre-existing health. The patient's life usually can be saved if the conditions causing shock are corrected within 1 hour or less of the onset of the progressive stage. We've got an hour. Refractory stage of shock or irreversible stage. The refractory stage or irreversible stage of shock occurs when too much cell death and tissue damage results from too little oxygen reaching the cells or reaching the tissues. Vital organs have overwhelming damage. This stage is termed refractory because the body can no longer respond effectively to interventions and shock continues. The remaining cells metabolize anaerobically. Therapy is not effective in saving the patient's life, even if the cause of shock is corrected and MAP temporarily returns to normal. So much tissue damage has occurred with widespread release of toxic metabolites and destructive enzymes that cell damage in vital organs continues despite aggressive interventions. Manifestations are a rapid loss of consciousness, non-palpable pulse, cold, mottled or dusky extremities, slow, shallow respirations, and unmeasurable saturation. Oh. Okay. Multiple organ dysfunction syndrome. The sequence of cell damage caused by the massive release of toxic metabolites and enzymes is termed multiple organ dysfunction syndrome, or MODS. Once the damage has started, the sequence becomes a vicious cycle as more dead cells break open and release harmful metabolites. The metabolites trigger small clots, or microthrombi, to form. The clots block tissue oxygenation and damage more cells, thus continuing the devastating cycle. MODS occurs first in the liver, heart, brain, and kidney. The most profound change is damage to the heart muscle. One cause of this damage is the release of myocardial depressant factor, or MDF, from the ischemic pancreas. Etiology. Hypovolemic shock occurs when too little circulating blood volume causes a MAP decrease that results in the body's total need for oxygen not being met. Common problems leading to hypovolemic shock are hemorrhage, external or internal, and dehydration. Hypovolemic shock caused by external hemorrhage is common after trauma and surgery. Hypovolemic shock caused by internal hemorrhage occurs with blunt trauma, GI ulcers, and poor control of surgical bleeding. External and internal hemorrhage can be caused by any problem that reduces the levels of clotting factors. See table 39.2. Hypovolemia is a result of dehydration. As a result of dehydration, can be caused by any problem that decreases fluid intake or increases fluid loss. See table 39.2. Incidence and prevalence. The exact incidence of hypovolemic shock is not known because it is a response rather than a disease. It is a common complication among hospitalized patients in emergency departments and after surgery or invasive procedures. Health promotion and maintenance. Although hypovolemic shock often occurs as a complication of surgical intervention or trauma, primary prevention is possible. Teach all people to prevent dehydration by having an adequate fluid intake during exercise and when in hot, dry environments. Urge people to prevent trauma and hemorrhage by using proper safety equipment and seat belts and being aware of hazards in the home or workplace. Secondary prevention of hypovolemic shock is a major nursing responsibility. Keep in mind that just being a patient in the acute care setting is a risk factor. Identify patients at risk for dehydration and assess for early manifestations. This is especially important for those who have reduced cognition or reduced mobility or who are on NPO status. Assess all patients who have invasive procedures or trauma for obvious or occult bleeding. Compare pulse quality and rate with baseline. Compare urine output with fluid intake. Check vital signs for patients who have persistent thirst. Assess for shock in any patient who develops a change in mental status, an increase in pain, or an increase in anxiety. Chart 39.2 lists NIC interventions for early detection of shock among hospitalized patients. When patients have invasive procedures or ambulatory surgery and then go home, teach them and their families the manifestations of shock. Stress the importance of seeking immediate help for obvious heavy bleeding, persistent thirst, decreased urine output, and lightheadedness or a sense of impending doom, a feeling that something bad is happening or going to happen. Chart 39.2, NIC intervention activities. Prevention of shock progression. Shock prevention. detecting and treating a patient for impending shock. Monitor for early compensatory shock responses, e.g., normal blood pressure, narrowed pulse pressure, mild orthostatic hypotension, 15 to 25 mmHg, slight delayed capillary refill, pale/cool skin or flushed skin, slight tachypnea, nausea and vomiting, increased thirst or weakness. Monitor possible sources of fluid loss, e.g. chest tube, wound, and nasogastric drainage, diarrhea, vomiting, and increasing abdominal girth and extremity girth. Hematemesis or hematochezia. Monitor circulatory status, e.g. blood pressure, skin color, skin temperature, heart sounds, heart rate and rhythm, presence and quality of peripheral pulses and capillary refill. Monitor for signs of inadequate tissue oxygenation, e.g. apprehension, increased anxiety, changes in mental status, agitation, oliguria, and cool mottled periphery. Monitor pulse oximetry. Monitor laboratory values, especially HGB and HCT levels, clotting profile, ABG, lactate level, electrolyte levels, cultures and chemical profile. Note bruising, petechiae, and condition of mucous membranes. Note color, amount, frequency of stools, vomitus, and nasogastric drainage. Test urine for blood and protein as appropriate. Place patient in supine, legs elevated position. Administer IV and/or oral fluids as appropriate. Insert and maintain a large bore IV access as appropriate. Administer oxygen and/or mechanical ventilation as appropriate. Patient-centered collaborative care. The concept map on page 834 addresses assessment and nursing care issues related to hypovolemic shock. Assessment, history. Collect data on risk factors and causative factors related to hypovolemic shock. If the patient is alert and stable, question him or her directly. If the patient is not alert, or if his or her condition is not stable, collect information from family members. Age is important because hypovolemic shock from trauma is more common in young adults, and other types of shock are more common in older adults. Ask patients specific questions about recent illness, trauma, procedures, or chronic health problems that may lead to shock. These problems include GI ulcers, general surgery, hemophilia, liver disorders, prolonged vomiting, and prolonged diarrhea. Ask about the use of drugs such as aspirin, diuretics, and antacids that may cause changes leading to hypovolemic shock or may indicate the presence of a problem that can contribute to shock. Ask about fluid intake and output during the previous 24 hours. Information about urine output is especially important because urine output is reduced during the first stages of shock, even when fluid intake is normal. Assess the patient for obvious signs or factors that can lead to shock. Areas to examine for signs of hemorrhage include the gums, wounds, and sites of dressings, drains, and vascular accesses. Also check under the patient for blood. Observe for any swelling or skin discoloration that may indicate an internal hemorrhage. Physical assessment, clinical manifestations. Most manifestations of hypovolemic shock are caused by the changes resulting from compensatory efforts. Adaptive or compensatory mechanisms are physiologic adjustments or responses that try to keep an adequate blood flow to vital organs. Signs of shock are first evident as changes in cardiovascular function. As shock progresses, changes in the renal, respiratory, integumentary, musculoskeletal, and central nervous systems become evident. When a patient is at risk for or is suspected of having hypovolemic shock, a registered nurse should perform the assessment and obtain vital signs rather than a licensed practical nurse, a licensed vocational nurse, or a unlicensed assistive personnel. Ensure that vital sign measurements are accurate and monitor them for trends indicating shock. Cardiovascular changes that occur with shock start with decreased mean arterial pressure, or MAP, leading to adaptive or compensation responses. Thus, the earliest clinical signs of hypovolemic shock are cardiovascular. Assess the central and peripheral pulses for rate and quality. In the initial stage of hypovolemic shock, the pulse rate increases to keep cardiac output and MAP at normal levels, even though the actual stroke volume, amount of blood pumped out of the heart per beat, is decreased. Increased heart rate is the earliest manifestation of shock. Because stroke volume is decreased, the peripheral pulses are difficult to palpate and are easily blocked with light pressure. As hypovolemic shock progresses, peripheral pulses may be absent. Changes in systolic blood pressure are not always present in the initial stage of shock and should not be used as the main indicator of shock presence or progression. When assessing the blood pressure of a patient at risk for shock, consider his or her normal baseline blood pressure. Although a blood pressure of 90/50 may indicate severe shock in one person, it may be normal blood pressure for another healthy adult. When vasoconstriction is present, diastolic pressure increases, but systolic pressure remains the same. As a result, the pulse pressure, which is the difference between the systolic and the diastolic pressure, is smaller, sometimes called narrower. Monitor blood pressure for changes from baseline levels and for changes from the previous measurement. For accuracy, use the same equipment on the same extremity. Validate an electrical or electronic reading with a manual reading. There's a concept map of hypovolemic shock. It's pretty cool. Okay, systolic pressure decreases as shock progresses and cardiac output decreases. A reduced systolic pressure narrows the pulse pressure even further. When shock continues and interventions are not adequate, compensation fails and both systolic and diastolic pressures decrease. At this stage, blood pressure is difficult to hear. Palpation or a Doppler device may be needed to detect the systolic blood pressure. Oxygen saturation is assessed through pulse oximetry. Pulse oximetry values between 90% and 95% occur with the non-progressive stage of shock, and values between 75 and 80% occur with the progressive stage of shock. Any value below 70% is considered a life-threatening emergency of shock, and any value below 70% is considered a life-threatening emergency and may signal the refractory stage of shock. Respiratory changes with shock are an adaptive or compensatory response to help maintain oxygenation when tissue perfusion is decreased. Assess the rate, depth, and ease of respiration, and auscultate the lungs for abnormal breath depth and ease of respiration, and auscultate the lungs for abnormal breath sounds. Respiratory rate increases during hypovolemic shock to ensure that oxygen intake is increased so that it can be delivered to critical tissues. When shock progresses to the stage at which lactic acidosis is present, the respiratory depth also increases. Renal and urinary changes occur with shock to adapt or compensate for decreased MAP by saving blood water through decreased filtration, and increased water reabsorption. Assess urine for volume, color, specific gravity, and the presence of blood or protein. A decrease in urine output is a sensitive indicator of early shock. Measure urine output at least every hour. In severe shock, urine output is decreased compared with fluid intake or even absent. Of the 4 vital organs, heart, brain, liver, and kidney, only the kidney can tolerate hypoxia and anoxia for up to 1 hour without permanent damage. When hypoxia or anoxia persists beyond this time, patients are at risk for acute tubular necrosis, or ATN, and kidney failure. Skin changes occur in shock because of reduced blood flow in the skin. An early adaptive or compensatory mechanism for hypovolemic shock is blood vessel constriction in the skin, which reduces skin perfusion. This allows more blood to circulate to the vital organs, which cannot tolerate low oxygen levels. Assess the skin for temperature, color, degree of moisture. With shock, it feels cool or cold to the touch and is moist. As shock progresses, color changes are first evident in the mucous membranes and in the skin around the mouth. Pallor or cyanosis is best assessed in the oral mucous membranes in dark-skinned patients. Color changes in patients with lighter skin are noted first in the extremities and then in the central trunk area. The skin feels clammy or moist to the touch, not because sweating increases, but because the normal fluid lost through the skin does not evaporate quickly on cold skin. As shock progresses, skin becomes mottled. Lighter-skinned patients have an overall grayish-blue color, and darker-skinned patients appear darker without an underlying reddish glow. Evaluate capillary refill time by pressing on the patient's fingernail until it blanches and then observing how fast the nail bed resumes color when pressure is released. Normally the nail bed capillaries resume color as soon as pressure is released. With shock, capillary refill is slow or is sometimes absent. Capillary refill may not be a reliable indicator for peripheral blood flow in older patients or those with anemia, diabetes mellitus, or peripheral vascular disease. Central nervous system changes with shock often first manifest as thirst. This sensation is caused by stimulation of the thirst centers in the brain in response to decreased blood volume. Assess the patient's level of consciousness and orientation to person, place, and time. Most causes of hypovolemic shock do not interfere with nerve impulse transmission. The central nervous system changes of hypovolemic shock are caused by cerebral hypoxia. In the initial and non-progressive stages, patients may be restless or agitated and may be anxious or have a feeling of impending doom that has no obvious cause. As hypoxia progresses, confusion and lethargy occur. Lethargy progresses to somnolence and loss of consciousness as cerebral hypoxia worsens. Skeletal muscle changes during shock are muscle weakness and pain in response to tissue hypoxia and anaerobic metabolism. These are later manifestations of shock. Weakness is generalized and has no specific pattern. The electrolyte changes of shock worsen muscle weakness by decreasing action potentials. Then deep tendon reflexes are decreased or absent. Assess muscle strength by having the patient squeeze your hand and by trying to keep his or her arms flexed while you attempt to straighten them. Assess deep tendon reflexes by lightly tapping the patellar tendons and Achilles tendons with a reflex hammer and observing the degree of reflexive movement. Psychosocial assessment. Changes in mental status and behavior may be early signs of shock. Observe the patient closely and document behavior. Assess current mental status by evaluating LOC and noting whether the patient is asleep or awake. If the patient is asleep, attempt to awaken him or her and document how easily he or she is aroused. If the patient is awake, determine whether he or she is oriented to person, time, and place. Avoid asking questions that can be answered with a yes or no response. Consider these points during assessment. Is it necessary to repeat questions? Oh, one moment. Okay, consider these points during assessment. Is it necessary to repeat questions to obtain a response? Does the response answer the question asked? Does the patient have difficulty making word choices? Is the patient irritated or upset by the questions? Can the patient concentrate on a question long enough to answer appropriately, or is the attention span limited? If possible, talk with family members to determine whether the patient's behavioral and mental status are typical or represent a change. Laboratory assessment. Although no single laboratory finding confirms or rules out shock, changes in laboratory data may support the diagnosis of hypovolemic shock. Chart 39.3. Chart 39.3 lists common laboratory findings occurring with hypovolemic shock. As shock progresses, arterial blood gas values become abnormal, the pH decreases, the partial pressure of arterial oxygen, or PaO2 decreases, and the partial pressure of arterial carbon dioxide, PaCO2, increases. Changes in other laboratory values may occur with specific causes of hypovolemic shock. Hematocrit and hemoglobin levels decrease if shock is caused by hemorrhage. When shock is caused by dehydration or a fluid shift, hematocrit and hemoglobin levels are elevated. Common nursing diagnosis and collaborative problems. Nursing diagnoses that may apply to patients with hypovolemic shock include ineffective tissue perfusion, general, related to hypovolemia; deficient fluid volume related to active fluid volume loss; decreased cardiac output related to hypovolemia; anxiety related to potential for death; disturbed thought processes related to decreased cerebral perfusion. Chart 39.3, laboratory profile, hypovolemic shock. Test pH, arterial 735 to 745 is normal. Significance of abnormal findings would be if it's decreased insufficient tissue oxygenation causing anaerobic metabolism and acidosis. PaO2 80 to 100 is normal. Decreased anaerobic metabolism. If it's decreased, it's anaerobic metabolism. PaCO2 35 to 45 is normal. If it's increased, it's anaerobic metabolism. Okay, lactic acid, arterial 0.3 to 0.8 is normal. Increased anaerobic, then in hypovolemic shock, then it's anaerobic metabolism with buildup of metabolites. Hematocrit 37 to 47 for females, 42 to 52 for males. Increased, you have a fluid shift, and dehydration. Decreased, it's hemorrhage. Hemoglobin, females 12 to 16, males 14 to 18. Increased, fluid shift, dehydration, decreased hemorrhage. Potassium 3.5 to 5, and that's increased dehydration and acidosis. Decision-making challenge. One moment. The patient is a 53-year-old man who had an open reduction of his right forearm after falling from a tree while trimming it. His only health problems are mild hypertension and being 15 pounds underweight for his height. His history includes that he smokes 2 packs of cigarettes and drinks a 6-pack of beer daily. When he comes to the day surgery recovery unit, his vital signs are BP 142/90, pulse 86, respirations 18, pulse oximetry 97. The dressing around his forearm is dry and intact. The fingers of his right hand are warm and pink with good capillary refill. When you call his name, he responds, although he does not open his eyes. Are any indications of shock currently present? Provide a rationale for your answer. Probably increased systolic and non-responsiveness. Okay, it is now 15 minutes later, and the patient's BP is 140/92, pulse is 92 respirations 18, pulse oximetry is 95%, the dressing is dry and intact, his fingers are slightly cool, and capillary refill is slightly slower than during the previous assessment. He is awake and tells you that his right arm hurts and that he is thirsty. You administer the prescribed analgesic by injection. 2. Are any indications of shock currently present? Provide a rationale for your answer. Yes. What should you check regarding the coolness of the fingers? Should you give him sips of water? Why or why not? In another 15 minutes, his vital signs have changed. BP 132/96, pulse 100 respirations 22. He tells you that the pain is much better, but that he is very thirsty and feels lightheaded and a little nauseated. He then belches twice. His post-operative orders read that the IV can be removed when 1,000 mL has infused if he is stable. Are any of the changes in vital signs a cause of concern? If so, which ones? Will the changes in vital signs be related to either his pain or the analgesic? Why or why not? Given his surgery, where should you look for bleeding? Should you remove his IV at this time? Why or why not? Should you wait 15 minutes before retaking his vital signs? You retake his vital signs in 10 minutes. BP 106/80, pulse 112, respirations 26, pulse oximetry is 90%. Just as you start to check his capillary refill, he says, "Josie," his wife's name, "bring me a bucket. I am going to be sick." With that, he vomits a large amount of bright red blood. Oh. Which vital sign changes are consistent with shock? Which stage of shock is present? What is the most likely cause of the bleeding? Is there anything a nurse could have done differently to identify shock earlier? Oh, yeah. Chart 39.4, best practice for patient safety and quality care. The patient in hypovolemic shock. Ensure a patent airway. Start an IV catheter or maintain an established catheter. Administer oxygen. Elevate the patient's feet, keeping his or her head flat or elevated to a 30-degree angle. Examine the patient for overt bleeding. If overt bleeding is present, apply direct pressure to the site. Administer drugs as prescribed. Increase the rate of IV fluid delivery. Do not leave the patient. Interventions. Medical and nursing interventions for patients in hypovolemic shock focus on reversing the shock, restoring fluid volume to the normal range, and preventing complications through supportive and drug therapies. The nursing role of monitoring is critical to determine whether the patient is responding to therapy or whether shock is progressing and a change in intervention is needed. Surgery may be needed to correct the problem leading to hypovolemic shock. Chart 39.4 lists best practices for patients in hypovolemic shock. Non-surgical management. The goals of shock management are to maintain tissue oxygenation, increase vascular volume and to normal range, and support compensatory mechanisms. Oxygen therapy, fluid replacement therapy, and drug therapy are useful for this problem. Chart 39.5 common examples of drug therapy. Hypovolemic shock. Okay, drug. Dopamine or intropin, Revamine, 520 micrograms per kilogram per minute on the IV. Purpose is to improve blood flow by increasing peripheral resistance, increasing venous return to the heart, and improving myocardial contractility. That also goes for norepinephrine or Levelfed. Initial dose 0.5 to 1 micrograms per minute IV to maintain systolic BP between 90 and 100 mmHg, and also phenylephrine, hydrochloric acid, 0.1 to hydrochloride, 0.1 to 0.5 milligrams IV every 15 minutes. Okay, and so that improves blood flow by increasing peripheral resistance, increasing venous return to the heart, and improving myocardial contractility. Interventions: assess the patient for chest pain, monitor urine output hourly, assess blood pressure every 15 minutes, assess the patient for headache, assess every 30 minutes for extravasation, I'm not sure what that is, and check extremities for color and perfusion. Assess for chest pain. I said that. Rationales: drug increases myocardial oxygenation consumption, higher doses decrease renal perfusion and urine output. Hypertension is a sign of overdose. Headache is an early symptom of drug excess. If the drug gets into the tissues, it can cause severe vasoconstriction, tissue ischemia, and tissue necrosis. Drug can cause rapid onset of vasoconstriction in the myocardium and impair cardiac oxygenation. Okay, that's those drugs. Now, inotropic agents. You have dobutamine or Dobutrex, 1 to 20 micrograms per kilogram per minute IV as continuous infusion. There's also milrinone or Primacor, 50 micrograms per kilogram bolus over 10 minutes, 0.3 to 0.75 micrograms per kilogram per minute continuous IV infusion. These drugs directly stimulate adrenergic receptors sites on the heart muscle, the beta-1 receptors, and improve heart muscle cell contraction. And interventions: you want to assess for chest pain and assess blood pressure every 15 minutes. Problems might be drug increases myocardial oxygenation consumption and can cause angina or infarction. Hypertension is a sign of overdose for inotropic agents. Okay, and then other drugs: agents enhancing myocardial perfusion. Okay, so you have sodium nitroprusside or Nitropress, and Nipride or Nipride, and that's 0.25 to 10 micrograms per kilogram per minute IV. And these drugs improves blood flow to the myocardium by dilating the coronary arteries. This effect is primary and rapid but short. Interventions: protect drug container from light and assess blood pressure at least every 15 minutes. Problems with sodium nitroprusside would be light degrades drug quickly. The vasodilating effect can cause systemic vasodilation and hypotension, especially in older adults. So back to the text, back to non-pharmacologic therapies. There's or interventions. There's oxygen therapy is useful whenever shock is present. Oxygen can be delivered by mask, hood, nasal cannula, nasal pharyngeal tube, endotracheal tube, or tracheostomy tube. Oxygen is given in liters per minute, L per min, when using a cannula, or concentration by percentage when using a mask. Okay. IV therapy or fluid resuscitation is a mainstay of management for hypovolemic shock. Crystalloids and colloids are the two types of fluids used for volume replacement during hypovolemia. Crystalloid solutions contain non-protein substances, e.g. minerals, salts, and sugars. Colloid solutions contain large molecules, including proteins or starches. See Chapter 13. Crystalloid fluids are given to help maintain an adequate fluid and electrolyte balance. Two common solutions are normal saline and Ringer's lactate. Normal saline, 0.9% sodium chloride in water, is the fluid replacement solution of choice used to increase plasma volume and can also be infused with any blood product. Ringer's lactate contains sodium, chloride, calcium, potassium, and lactate dissolved in water. This isotonic solution expands volume and the lactate buffers any acidosis. Do not infuse this solution with blood or blood products because the calcium induces clotting of the infusing blood. Okay, don't put it in blood transfusions. It induces calcium clotting. Calcium induces clotting. Okay, protein-containing colloid fluids. Protein-containing colloid fluids help restore osmotic pressure and fluid volume. Blood and blood products are often used for this purpose when shock is caused by blood loss. These fluids include whole blood, packed red blood cells, plasma, plasma fractions, and synthetic plasma expanders. Whole blood and packed red blood cells increase hematocrit and hemoglobin levels along with fluid volume. Whole blood is used to replace large volumes of blood loss because it increases volume and improves the oxygen carrying capacity of the blood. Packed red cells are given for moderate blood loss because they restore the red blood cell deficit and improve oxygen carrying capacity without adding excessive fluid volume. Chapter 42 discusses nursing care issues when giving blood or blood products. Human plasma, an acellular blood product containing some clotting factors, is given to restore osmotic pressure when hematocrit and hemoglobin levels are within normal ranges. Plasma protein fractions, e.g. plasminate, and synthetic plasma expanders, e.g. hetastarch, hydroxyethol, whatever, starch, and hespan, increase plasma volume and are used as early treatment for hypovolemic shock before a cause has been established. Drug therapy may be needed if the volume deficit is severe and the patient does not respond sufficiently to the replacement of fluid volume and blood products. The actions of drugs for shock increase venous return, improve cardiac contractility, or improve cardiac perfusion by dilating the coronary vessels. Chart 39.5 lists the drugs used to treat hypovolemic shock. Constricting drugs stimulate venous return by constricting blood vessels and decreasing venous pooling of blood. These actions increase cardiac output and mean arterial pressure, or MAP, which help improve tissue perfusion and oxygenation. Such agents include dopamine or intropin, revamine, and norepinephrine or Levophed. These drugs can produce serious side effects, and their dosages must be carefully calculated on the basis of the patient's size and response to treatment. Inotropic drugs directly stimulate adrenergic receptors on the heart muscle, or beta-1 receptors, and improve heart muscle cell contraction. Thus, greater recoil occurs and more blood leaves the left ventricle during contraction. Some of these drugs also stimulate the ventricles, Drugs with these actions include dobutamine or Dobutrex and milrinone or Primacor. Drugs enhancing myocardial perfusion help ensure that the heart is well perfused, especially when giving drugs to improve cardiac contraction, so that aerobic metabolism is maintained in the heart cells and maximum contractility can occur. Drugs that dilate coronary blood vessels while minimally dilating systemic vessels are used for this purpose. A common drug with this action is sodium nitroprusside or nitropres or nipride. Care is taken because these drugs can cause systemic vasodilation and increase shock if the patient is volume depleted. Monitoring vital signs and level of consciousness is a major nursing action to determine the patient's condition and effectiveness of therapy. Monitor pulse, blood pressure, pulse pressure, central venous pressure, CVP, respiratory rate, skin and mucosal color, oxygen saturation, mental status, and urine output. Assess these parameters at least every 15 minutes until the shock is controlled and the patient's condition improves. Hemodynamic monitoring is critical care in critical care settings includes intra-arterial monitoring, mixed venous oxygen saturation or SVO2, pulmonary artery monitoring, and pulmonary capillary wedge pressures. Insertion of a CVP catheter allows pressure to be monitored in the patient's right atrium or superior vena cava while providing venous access. Changes in CVP reflect hypovolemic shock. As circulating volume decreases, the amount of blood returning to the right atrium also decreases, causing the CVP to decrease from baseline levels. Intra-arterial catheters allow continuous monitoring of blood pressure and are an access for arterial blood sampling. Intra-arterial catheters are inserted into an artery, radiobrachial, femoral, or dorsalis pedis. The catheter is attached to pressure tubing and a transducer. The transducer converts pressure in the artery into an electrical signal that is seen as a visible waveform on an oscilloscope and as digital numeric value. Surgical management. The non-surgical interventions described on page 836 to 838 are used to stabilize the patient's hemodynamic status. After a cause has been established, surgical intervention may be needed to correct the cause of shock. Such procedures include vascular repair or revision, surgical hemostasis of major wounds, closure of bleeding ulcers, and chemical scarring or chemosclerosis of varicosities. Community-based care. Hypovolemic shock is a complication of another condition and is resolved before patients are discharged from the acute care setting. Because more patients are receiving treatment on an outpatient basis and are being discharged earlier from acute care settings, especially after surgery and other invasive procedures, more patients at home are at increased risk for hypovolemic shock. Teach patients and family members the early manifestations of shock: increased thirst, decreased urine output, lightheadedness, unexplained sense of apprehension, and to seek immediate medical attention if they appear. It's hypovolemic shock. Okay, now pages 816 to 821. DVT, deep vein thrombosis. Starts off venous thromboembolism. Pathophysiology. Venous thromboembolism, or VTE, is one of healthcare's greatest challenges and includes both thrombus and embolus complications. A thrombus, also called a thrombosis, is a blood clot believed to result from an endothelial injury. Venous stasis, or hypercoagulability. Coagulability. The thrombosis may not be specifically attributable to one element, or it may involve all three elements: endothelial injury, venous stasis, or hypocoagulability. It is often associated with an inflammatory process. When a thrombus develops, inflammation occurs around the clot, thickening the vein wall and consequently possibly leading to embolism, the formation of an embolus. Thrombophlebitis refers to a thrombus that is associated with inflammation. Phlebothrombosis is a thrombus without inflammation. Thrombophlebitis can occur in superficial veins. However, it most frequently occurs in the deep veins of the lower extremities. Deep vein thrombophlebitis, or DVT, commonly referred to as deep vein thrombosis, or DVT, not only is most common, but also is more serious than superficial thrombophlebitis because it presents a greater risk for pulmonary embolism, or PE. In PE, a dislodged blood clot travels to the pulmonary artery. DVT develops most often in the legs, but can occur also in the upper arms as a result of an increased use of central venous devices. Thrombus formation has been associated with stasis of blood flow, endothelial injury, and or hypocoagulability, known as Virchow's triad. The precise cause of these events remains unknown. However, a few disposing factors have been identified. Thrombosis has commonly occurred in people undergoing certain surgical procedures. The highest incidence of clot formation occurs in patients who have undergone hip surgery, total knee replacement, or open prostate surgery. Other conditions that seem to promote thrombus formation are ulcerative colitis, heart failure, and immobility. Complications of immobility occur during prolonged bed rest, such as when a patient is confined to a bed for an extensive illness. People who sit for long periods, e.g. on an airplane, are also at risk for VTE. Phlebitis, vein inflammation, associated with invasive procedures such as IV therapy, can predispose patients to thrombosis. Severe infections, systemic lupus, erythematosus, polycythemia vera, oral contraceptives, and trauma have also been linked to thrombosis. Cancer, especially adenocarcinoma of the visceral organs, is the most common malignancy associated with DVT. Cancer has been discovered in nearly all people with fatal PEs who did not have other predisposing factors. Millions of people in the United States are affected by DVT each year, and many die from pulmonary embolism. The largest number of deaths occur in older adults. African Americans have a high rate of death resulting from PE because of predisposing risk factors and coexisting diseases such as certain cancers and chronic renal and cardiac failure. Health promotion and maintenance. In the community, if a person has a history of VTE, these precautions should be taken. Avoid oral contraceptives. Drink adequate fluids to avoid dehydration. Exercise legs during long periods of bed rest or sitting. In the inpatient setting, interventions to prevent VTE include patient education, leg exercises, early ambulation, adequate hydration, graduated compression stockings, not as commonly used today, intermittent pneumatic compression such as sequential compression devices, or SCDs, venous plexus foot pump. Patient-centered collaborative care assessment. People with DVT may have symptoms or may be asymptomatic. The classic signs and symptoms of DVT are calf or groin tenderness and pain and sudden onset of unilateral swelling of the leg. Pain in the calf or on dorsiflexion of the foot is a positive Homan's sign, appears in only a small percentage of patients with DVT, and false positive findings are common. Therefore, checking a Homan's sign is not advised! Exclamation point. Examine the area described as painful. Compare the site with the other limb. Gently palpate the site. observing for induration or hardening along the blood vessel, and for warmth and edema. Redness may also be present, figure 38.8. Localized edema in one extremity may suggest thrombophlebitis. Some experts suggest to measure and compare right and left calf and thigh circumferences for changes over time as an indicator of DVT or venous insufficiency. However, serial leg measurements are not the most reliable indicator of DVT. DVT can occur also in the arm from an indwelling IV catheter or from compression injuries to the arm or subclavian vein by a rib. Although diagnostic tests are available, physical examination findings are often adequate for diagnosis. If a definitive diagnosis is lacking from physical assessment findings alone, diagnostic tests, e.g. duplex ultrasonography, Doppler flow studies, impedance plethysmography may be performed. The preferred diagnostic test for DVT is venous duplex ultrasonography, a non-invasive test. Doppler flow studies may also be used in the diagnosis, but they are more sensitive in detecting proximal rather than distal DVT. Normal venous circulation creates audible signals, whereas thrombosed veins produce little or no sound. The accuracy of the scanning depends on the technical skill of the healthcare professional performing the test. If the test is negative but a DVT is still suspected, a venogram may be needed to make an accurate diagnosis. However, venograms are not performed frequently today because of complications with the contrast medium, including sensitivity and acute renal failure. Impedance plethysmography assesses venous outflow and can detect most DVTs that are located above the popliteal vein, the knee. However, it is not helpful in locating clots in the calf and is less sensitive than Doppler studies. Magnetic resonance direct thrombus imaging, MRI, another non-invasive test, is useful in finding a DVT in the proximal deep veins and is better than transitional venography in finding DVT in the inferior vena cava or pelvic veins. A D-dimer test is a global marker of coagulation activity and measures fibrin degradation products produced from fibrinolysis or clot breakdown. The test is used for the diagnosis of DVT when the patient has few clinical signs and stratifies patients into a high-risk category for reoccurrence. Useful as an adjunct to non-invasive testing, a negative D-dimer test can exclude a DVT without an ultrasound. Okay. Common nursing diagnoses and collaborative problems. Nursing diagnoses that may apply to patients with DVT include risk for ineffective tissue perfusion, peripheral, related to interruption of venous blood flow, acute pain related to physical injury agent thrombus. The most common collaborative problem is potential for embolism. Interventions. The focus of managing thrombophlebitis is to prevent complications such as pulmonary emboli, prevent further thrombus formation, and prevent an increase in the size of the thrombus. Deep vein thrombophlebitis, thrombosis, is the most common type of thrombophlebitis. Patients with DVT are often hospitalized for treatment, although this practice is changing as a result of the use of newer drugs. Non-surgical management. DVT is usually treated medically using a combination of rest, drug therapy, and preventative measures. Prevention of DVT is crucial for patients at risk. Preventative measures are listed on page 817 in the Health Promotion and Maintenance section. Rest. Supportive therapy for DVT includes bed rest and elevation of the extremity. Teach the patient to elevate his legs or her legs when in bed and in a chair. To help prevent chronic venous insufficiency, instruct patients with active resolving DVT to wear knee or thigh-high compression or elastic stockings for an extended period. Some healthcare providers prescribe intermittent or continuous warm, moist soaks to the affected area. Do not massage the affected extremity to prevent the thrombus from dislodging and becoming an embolus. All patients are evaluated for signs and symptoms of pulmonary embolism, or PE, which include shortness of breath and chest pain. Emboli may also travel to the brain or heart, but these complications are not as common as PE. Chapter 34 describes PE manifestations in detail. Drug therapy. Anticoagulants are the drugs of choice for actual DVT and for patients at risk for DVT. The conventional treatment has been IV unfractionated heparin, followed by oral anticoagulation with warfarin or Coumadin. However, unfractionated heparin can be problematic because each patient's response to the drug is unpredictable, and hospital admission is usually required for laboratory monitoring and dose adjustments. The use of low molecular weight heparin, LMWH, is changing the management of both DVT and PE. Unfractionated heparin therapy. Many patients with a confined or confirmed diagnosis of an existing blood clot are started on a regimen of IV unfractionated heparin, UFH, or hepaline therapy. UFH is an anticoagulant agent that at low doses interacts with antithrombin 3 to produce selective inhibition of clotting factors 2A, or thrombin, and XA. At higher doses, it inhibits practically all clotting factors. The ultimate result is inhibition of fibrin formation. The physician prescribes UFH to prevent the formation of other clots, which often develop in the presence of an existing clot, and to prevent enlargement of the existing clot.
Like first you existed, and now we've got these other clots.
Over a long period, the existing clot is slowly absorbed by the body. Before UFH administration, a baseline prothrombin time, PT, activated partial thromboplasmin time, APTT, or APTT, little a, international normalized ratio, INR, complete blood count, CBC, with platelet count, urinalysis, stool for occult blood, and creatinine level are required. Notify the physician if the platelet count is below 120,000 mm to the third. UFH is initially given in a bolus 4 dose of about 80 to 100 units per kilogram of body weight, or 5,000 units, followed by continuous infusion. The infusion is regulated by a reliably electronic pump that protects against accidental free flow of solution. The physician or clinical pharmacist prescribes concentrations of UFH in 5% dextrose and water, and the number of units or milliliters per hour needed to maintain a therapeutic APTT, usually 18 to 20 units per kilogram per hour, or at least 30,000 units over 24 hours. APTT is measured at least daily, and results are reported to the healthcare provider as soon as results are available to allow adjustment of heparin dosage. The therapeutic levels of APTTs are usually 1.5 to 2 times normal control levels. Notify the physician if the value is greater than 70 seconds, or follow hospital protocol for reporting critical laboratory values. Assess patients for signs and symptoms of bleeding, which include hematuria, frank or occult blood in the stool, ecchymosis or bruising, petechiae, and altered level of consciousness or pain. UFH can also decrease platelet counts. Mild reductions are common and are resolved with continued heparin therapy. Severe platelet reduction, although rare, result from the development of antiplatelet bodies within 6 to 14 days after the beginning of treatment. Platelets aggregate into white clots that can cause thrombosis, usually in the form of an acute arterial occlusion. The provider discontinues heparin administration if severe heparin-induced thrombocytopenia, or HIT, platelet count over 150,000, or white clot syndrome occurs. LMWH is used more commonly today because of the complications involved with UFH, or low molecular weight heparin. For LMWH. Bivalirudin, or Angiomax, and Lepirudin, Refludin, are highly selective direct thrombin inhibitors that may be used as alternatives to heparin or for patients who have had HIT. Like heparin, these drugs increase the risk for bleeding. An oral anticoagulant like warfarin or Coumadin may also be substituted for heparin if necessary. Ensure that protamine sulfate, the antidote for heparin, is available if needed for excessive bleeding. Chart 38.6 highlights information important to nursing care and patient education associated with anticoagulant theory. To prevent DVT, heparin may be given in low doses subcutaneously for high-risk patients, especially after orthopedic surgery. However, other drugs are used more often, including low molecular weight heparin, e.g. Lovenox, drug class of choice after orthopedic surgery. Chart 38.6, best practice for patient safety and quality care. The patient receiving anticoagulant therapy carefully check the dosage of anticoagulant to be administered even if the pharmacy prepared the drug. Monitor the patient for signs and symptoms of bleeding, including hematuria, frank or occult blood in the stool, ecchymosis, petechiae, altered mental status, including possible cranial bleeding, or pain, especially abdominal pain, which could indicate abdominal bleeding. Monitor vital signs frequently for decreased blood pressure and increased pulse, indicating possible internal bleeding. Have antidotes available as needed, e.g. protamine sulfate for heparin, vitamin K for warfarin, Coumadin, Warfarin. Monitor activated partial thromboplastin time, APTT, for patient receiving unfractionated heparin. Monitor prothrombin time, or PT, or INR, for patients receiving warfarin or low molecular weight heparin, LMWH. Apply prolonged pressure over venipuncture sites and injection sites. When administering subcutaneous heparin, apply pressure over the site and do not massage. Teach the patient going home while taking anticoagulant to use an electric razor. Take precautions to avoid injury. For example, do not use tools such as hammers or saws where accidents commonly occur. Report signs and symptoms of bleeding, such as blood in the urine or stool, nosebleeds, ecchymosis or bruising, or altered mental status. Take the prescribed dosage of drug at the precise time that it was prescribed to be given. Not stop taking the drug abruptly. The physician usually tapers the anticoagulant gradually. Back to the text. Talking about to prevent DVT, heparin may be given in low doses subcutaneously for high-risk patients, especially after orthopedic surgery. However, other drugs are used more often, including other drugs are used more often, low molecular weight heparin, Lovenox, especially after orthopedic surgery, selective factor XA inhibitors, e.g. Fondaparinux or Arextra, warfarin or Coumadin, Warfarin. Low molecular weight heparin. Subcutaneous low molecular weight heparins, such as enoxaparin, Lovenox, dalteparin or Fragmin, and arteparin or Normaflow, have a consistent action and are preferred for prevention and treatment of DVT. Danapiroid or Orgaron is also classified as an LMWH, but is actually a heparinoid. LMWHs bind less to plasma proteins, blood cells, and vessel walls, resulting in longer half-life and more predictable responses. These drugs inhibit thrombin formation because of reduced factor IIa activity and enhanced inhibition of factor XA and thrombin. Some patients taking LMWH may be safely managed at home with daily visits from a home care nurse. Candidates for home therapy must have stable DVT or PE, low risk for bleeding, adequate renal function, and normal vital signs. They must be willing to learn self-injection or have a family member, friend, or home care nurse administer the subcutaneous injections. Some healthcare providers place the patient on a regimen of IV unfractionated heparin or UFH for several days and then follow up with an LMWH. In this case, the UFH is discontinued at least 30 minutes before the first LMWH injection. The usual dose of enoxaparin is, or Lopinox, right? Yeah, is 1 milligram per kilogram of body weight, not to exceed 90 milligrams, and is repeated every 12 hours. If the patient's creatinine level is greater than 2 milligrams per deciliter, indicating renal insufficiency, the healthcare provider lowers the dose. Dalteparin can be given once daily at 200 units per kilogram of body weight and does not require dose adjustment for renal insufficiency. The usual dose of arteparin is 50 units per kilogram of body weight and is given every 12 hours. Monitor INR daily. Assess all stools for occult blood. The APTTs are not checked on an ongoing basis because the doses of LMWH are not adjusted. Warfarin therapy. If the patient is receiving continuous UFH, warfarin or Coumadin, an oral anticoagulant, may be added at least 5 days later. Patients receiving LMWH are placed on the oral drug after the first dose. Warfarin works in the liver to inhibit synthesis of the 4 vitamin K-dependent clotting factors and takes 3 to 4 days before it can exert therapeutic anticoagulation. The heparin continues to provide therapeutic anticoagulation until this effect is achieved. IV heparin is then discontinued. Therapeutic levels of warfarin are monitored by measuring PT and or the INR because PTs are often inconsistent and misleading. The INR was developed because PTs are often inconsistent and misleading. The INR was developed. Most laboratories report both results. Most patients receiving warfarin should have an INR between 1.5 and 2 to prevent future DVT and to minimize the risk of stroke or hemorrhage. For patients with additional cardiovascular problems, the desired INR may be higher. Warfarin therapy should be started with low doses, at least 5 mgs, and gradually titrated up according to the INR. Patients usually receive this drug for 3 to 6 months or longer after an episode of DVT if no precipitating factors were discovered with recurrence or if there are continuing risk factors. Nursing assessment for bleeding is similar to that described for patients receiving heparin. Ensure that vitamin K, the antidote for warfarin, is available in case of excessive bleeding. See chart 38.6. However, anticoagulation is not possible for 3 weeks after vitamin K administration. Thrombolytic therapy. The use of systemic thrombolytic therapy for DVT is effective in dissolving thrombi quickly and completely. The greatest advantage is thought to be the prevention of valvular damage and venous insufficiency or post-phlebitis syndrome. However, because of increased bleeding risk, thrombolytic therapy is contraindicated after surgery and after trauma, strokes, or spinal injuries. To be most effective, thrombolytic therapy must be started within 5 days after the onset of symptoms. Thrombolytic drugs such as a recombinant tissue plasminogen activator, or TPA, and platelet inhibitors such as abciximab or Riopro, tirofiban or Aggrastat, and eptifibatide or Integralin may be effective in dissolving a clot or preventing new clots during the first 24 hours. Infusion given via a catheter can be injected directly into the thrombus. Compared with giving systemic thrombolytic dosing, this approach decreases the concentration needed and reduces the chance of bleeding. Thrombolytic drugs such as alteplase and reteplase or alteplase and reteplase are used to treat peripheral vascular occlusion. Reteplase is a plasminogen activator that penetrates the clot and causes lysis. It is not compatible with heparin and should not be given in the same IV line. Reteplase has been used successfully in treating coronary thrombosis. Use in peripheral vascular occlusion is experimental. The most serious complication from thrombolytic therapy is intracerebral bleeding. Be aware of the importance of thrombolytic therapy, its indications, and its implications for nursing care. Closely monitor patients for signs and symptoms of bleeding, including a decreased level of consciousness. Decision-making challenge. Critical rescue. A middle-aged woman is a consultant who has traveled every week by plane for 15 years. Recently, she noticed redness and swelling in her left mid-calf with swollen ankles. The area is very painful, especially when she climbs stairs. The patient has a history of smoking and hypertension. She sees her health care provider, who admits her immediately to the hospital. Why do you think this patient was admitted on an urgent basis to the hospital? She had a thrombus. What risk factors does she have that predispose her to health? Being on the plane, redness, swelling, left mid-calf, swollen ankles, pain, smoking, hypertension. What type of drug do you think will be prescribed, and what are your nursing responsibilities when giving this drug? I don't know. What other nursing care, including health teaching, will this patient require? And during her second hospital day, the patient reports chest pain and shortness of breath. What is your priority action, and why do you think she has these symptoms? She has PE from an embolus, but I don't know what you're supposed to give her. Probably said before. A deep vein thrombosis, or surgical management. A deep vein thrombosis is rarely removed surgically unless there is a massive occlusion that does not respond to medical treatment and the thrombus is of recent 1 to 2 days onset. Thrombectomy is the most common surgical procedure for removing the clot. Preoperative and postoperative care of patients undergoing thrombectomy are similar to the care for those undergoing arterial surgery. See page 808 in the peripheral arterial disease section. Inferior vena caval interruption. Recurrent deep vein thrombosis, or DVT, or pulmonary emboli that do not respond to medical treatment, and for patients who cannot tolerate anticoagulation, inferior vena caval interruption may be indicated to prevent pulmonary emboli. Preoperative care is similar to that provided for patients receiving local anesthesia. See Chapter 16. If they have recently been taking anticoagulants, collaborate with the physician about interrupting this therapy in the preoperative period to avoid hemorrhage. The surgeon usually inserts a filter device or umbrella into the femoral vein. The device is meant to trap emboli in the inferior vena cava before they progress to the lungs. Holes in the device allow blood to pass through, thus not significantly interfering with the return of blood to the heart. Popular inferior vena caval filters include the bird's nest filter and the Greenfield filter. Postoperatively, inspect the groin insertion site for bleeding and signs of symptoms of infection. Other postoperative nursing care is similar to that for any patient undergoing local surgery. See Chapter 18. Ligation or external clips. If an inferior vena caval filter is not successful in preventing pulmonary emboli, or if the filter becomes blocked with thrombi, the surgeon may perform ligation or insert external clips on the inferior vena cava to prevent pulmonary emboli. Preoperative care for patients undergoing ligation of the vena cava or placement of an external clip is similar to that for an abdominal laparotomy. laparotomy. If the patient is receiving anticoagulation therapy, collaborate with the surgeon about temporary interruption of therapy. Ligation and insertion of external clips in the inferior vena cava are often performed through an abdominal laparotomy. There we go. In a ligation, the surgeon ties off the inferior vena cava to block emboli. Application of an external clip narrows the inferior vena cava to 4 serrated transverse slits, 3 to 5 milliliters in diameter. If laparotomy is performed, the external clip procedure is preferred because there are fewer hemodynamic or venous complications and a low frequency of recurrent pulmonary emboli associated with its use. Postoperative care for the patient with inferior vena caval ligation or external clip placement is similar to that for an abdominal laparotomy. Community-based care. Patients recovering from thrombophlebitis or DVT are usually ambulatory when they are discharged from the hospital. The primary focus of planning for discharge is to educate the patient and family about the hazards of anticoagulation therapy. Teach patients recovering from DVT to stop or avoid smoking and to avoid use of oral contraceptives to decrease the risk of recurrence. Alternative forms of birth control may be used. Most patients are discharged on a regimen of warfarin, Coumadin, or low molecular weight heparin. Instruct patients and their families to avoid potentially traumatic situations such as participation in contact sports. Provide written and oral information about the signs and symptoms of bleeding, see chart 38.6. Reinforce the need to report any of these manifestations to the healthcare provider immediately. The anticoagulant effect of warfarin may be reversed by omitting 1 or 2 doses of the drug or by the administration of vitamin K. In case of injury, teach patients to apply pressure to bleeding wounds and to seek medical assistance immediately. Encourage them to carry an identification card or wear a medical alert bracelet that states that they are taking warfarin or any other anticoagulant. Also instruct patients to tell their dentists and other healthcare providers that they are taking warfarin before receiving treatment or prescriptions. Prothrombin times are affected by many prescription and over-the-counter drugs such as NSAIDs. The action of warfarin is also affected by high-fat and vitamin K-rich foods, such as cabbage, cauliflower, broccoli, asparagus, turnips, spinach, kale, fish, and liver. Therefore, instruct patients to eat a well-balanced diet with moderate amounts of vitamin K and to avoid taking additional drugs without consulting a health care provider, chart 38.7. Teach patients also to prevent dehydration and to avoid alcohol and sitting for prolonged periods. In collaboration with the case manager or CM or other discharge planner, arrange for patients to obtain a device to monitor INR at home. This device is similar to a glucometer for glucose testing and requires a finger stick blood sample applied to a test strip or plastic cuvette, which is then inserted into the machine. Self-monitoring can be used as either the testing alone or for self-management, in which the patient uses the test results to adjust drug dosages based on dosing protocol. If the patient cannot use a monitoring device, teach a family member or other caregiver how to perform the procedure. If the patient lives alone, collaborate with the case manager to arrange for follow-up laboratory appointments, to have blood drawn at frequent intervals, usually every week until the patient's values are stabilized. Chart 38.7, Patient Family Education Guide. Food and drugs that interfere with warfarin, Coumadin. Eat small amounts of foods rich in vitamin K each day, including any of these: broccoli, cauliflower, spinach, kale, green leafy vegetables, Brussels sprouts, cabbage, liver. If possible, avoid allopurinol, NSAIDs, acetaminophen, vitamin E, histamine blockers, cholesterol-reducing drugs, antibiotics, birth control pills, antidepressants, thyroid drugs, everything, antifungal infections, other anticoagulants, corticosteroids, herbs such as St. John's wort, garlic, ginseng, and ginkgo biloba. Patients receiving subcutaneous LMWH injections at home need instruction on self-injection. Teach the appropriate caregiver and family members or friends, if necessary, to administer the injections. Patients who have experienced DVT may fear recurrence of thrombus. They may also be concerned about treatment with warfarin and the risk for bleeding. Assure them that the prescribed treatment will help resolve this problem and that ongoing assessment of PTs and INRs decreases the risk of bleeding. Patients discharged on a regimen of warfarin need access to a pharmacy to renew prescriptions and obtain a medical alert bracelet. They also need access to a laboratory for frequent monitoring of PTs and INRs unless they are self-monitoring. And that was DVT, pages 816 to 821.